My name is Siobhan Reynolds, and I'm standing in for my colleague Roisin Breen, who has gone on maternity leave. And I'm here with Naomi, and we'll be looking after QITalktime today. And thanks to Naomi for keeping everything running so smoothly. So this is our fourth talk time since September, and I'm delighted to introduce Angela Teisel today, along with Catherine Hand. And Angela and Catherine's webinar is about maintaining the principles of open disclosure during a coronavirus pandemic. Angela is the national lead for open disclosure for the HSE, and she's the manager of the Open Disclosure Office and Programme. Angela's background is nursing and midwifery, and with various clinical specialist posts. I mean, she's passionate about the rights of patients to be communicated within an open and honest manner. Angela has been leading the programme for 10 years now. Catherine has joined Angela in the programme as trainer and educator for open disclosure, and she's been with the programme for 18 months. And prior to that, she worked in patient advocacy in the acute setting. Before we hear from Angela and Catherine today, I just wanted to cover some housekeeping issues with regard to the QITalktime today. The dial-in number is 015260058. The event number is 137-422-0394#. And you can use your computer or phone to hear the talk time. Some people find the phone line is a better way of hearing. We'll have the chat box active throughout the webinar. And if you want to add a comment or suggestion, we try and keep it as interactive as possible. So just post it to everyone within the webinar. And we'll take your questions at the end then for Angela and Catherine. Just to note, we will be recording this QITalktime, and we'll also make the slides available on our website. So without further ado, I'll hand over to Catherine and Angela. Thanks very much.
Okay, thank you very much, Siobhan and Naomi, and Catherine. Both Catherine and I are delighted to be able to present to you all today on a topic very close to our heart around open disclosure, and particularly how it relates to the coronavirus pandemic and in particular the restrictions we're all experiencing around COVID-19. And just to give some of the background maybe to today's webinar is that very early when COVID-19 hit, our office started to get some queries around, difficulties that people were experiencing with managing open disclosure because of all the communication challenges that COVID-19 was presenting for people. So we very quickly realised that, we needed to very quickly pull something together to get kind of guide staff to actually manage some of those challenges that people were dealing with on a day-to-day basis. So really, I suppose, just to start off with, the ethos of our policy has always been around doing the right thing for our patients when things go wrong, and communicating with our patients every day in relation to all aspects of their care in an open, honest and compassionate way, but particularly when things go wrong, that we communicate quickly and we do it in a way that's compassionate and empathic. And there are numerous reasons why things go wrong during a patient's healthcare journey, and it's not just when we make a mistake or fail in some way, but it can be related to anything that goes wrong and related to their care, be it a risk that materialises. But no matter what the reason is, if a patient experiences a bad outcome, we sit down and talk to them very quickly to make sure they understand that and to empathise with them. Sorry, my screen seems to be stuck here now. Try again here. Okay, Siobhan, I'm having some IT problems here. Naomi?
Naomi, would you like to take over? It seems to have reset itself there.
That's okay. Sorry, it is reset now. I think it seems to be okay again.
Yeah.
I'll try and share again, Naomi, okay? Okay, I seem to have it back here again, I think. Yeah. All right. No, we're stuck again, Naomi. Yeah, we got back here again. So just looking at some of the values around open disclosure, and we think about every day, you know, and how we communicate generally, but particularly at the minute with COVID-19, just thinking about some of our values that we work to and aspire to every day in the work that we do with our patients: care, compassion, trust, learning, and kindness and empathy. And particularly at the moment, that trying to walk in the shoes of our patients, their families, and our staff, and the difficulties that they've been experiencing, particularly our frontline staff. So some of the communication challenges that have been brought to us through COVID-19 is the whole area around restricted movement, quarantine, self-isolation, cocooning, the need for personal distancing, and the fact that there's been major visitor restrictions, and indeed for a long time where visitors weren't allowed at all into our healthcare service to visit their loved ones, and particularly in the care of the elderly and our acute settings. The risk of exposure as well to COVID-19 for patients, their loved ones, and for our staff. Trying to communicate while wearing full personal protective equipment, which has major challenges on its own, and then communicating with people when they're ill as well, which is an ongoing, I think, for all of us, and not just COVID related. So just looking at the impact for staff, patients, and their loved ones. So the difficulty around having open disclosure meetings, and obviously the face-to-face meeting is the preferred option for open disclosure. So the challenges that COVID-19 has brought is that it hasn't been feasible or safe to have to hold face-to-face meetings with patients and their families. The PPE that creates distancing, it can reduce the whole human interaction that is so important when we sit down and have these very difficult conversations with our patients. The difficulty to see the person and to hear what they're saying because of having the masks on. Staff concern that their humanity is hidden behind the PPE, because we know that, you know, when we're talking to somebody, the facial expression is so important, watching the patient or the person's mouth as they speak as well. But the fact that we're in PPE is that staff feel hidden behind that, and the whole human interaction can get lost. The inability as well to provide physical comfort, such as things that we naturally do when we're comforting somebody, such as holding their hand, for example, or just gently touching a patient. Conversations may be shortened because we don't want to, expose the patient to risks around COVID, etc. Fear for everybody, for our patients, their families and staff, of getting COVID-19 and bringing COVID-19 back to their loved ones. The loneliness and isolation that COVID-19 has brought for everybody, patients maybe not being able to have their loved one present with them, and indeed, looking at some of the terrible stories we've heard of patients dying alone, and their loved ones being brought into the room maybe through communication via video or through the telephone. And these are just some awful stories that we've been hearing around COVID-19. And the fact that some communications have been limited to telephone communications. And then staff are dealing with the personal and professional impact of COVID-19, with the increased workload, reduced staffing, time, the discomfort of wearing PPE, and the worry about getting COVID-19 and infecting family members with that. And I just bring Catherine in here for a moment. Catherine has been working with us for about 18 months now, but when COVID-19 hit, Catherine went back into her previous role in PALS in Limerick Hospital, and a big part of her work there was involved with being that person who communicated with patients and their families. So Catherine, you might come in here maybe and just speak to us a bit around some of the things that you experience as a person who is doing this work on a day-to-day basis.
Thank you, Angela. Yes, I suppose I had worked in the patient advocacy role for over 4 years prior to joining Open Disclosure Office, but going back into the hospital then in March, we were dealing with a lot of situations that would be challenging to manage at the best of times, but then all those additional challenges of patients not having their families with them, and being in a situation where everyone around them is wearing PPE and all the challenge around communicating then really, really struck me. Everything took so much longer because you had to put your PPE on and check that everything was that you had everything before you went into a patient's room. I suppose being very important to try and establish a good relationship with the patient, to communicate with them well. Some staff would put their names on their PPE so the patient could see what their name was and their role. Some people even actually use photographs so the patient could see what they looked like. I was very mindful if there was a window in the room to let the person see my face either through the window or initially at the door before I would put on a mask and visor. And be very careful around making eye contact so they could feel a connection with you. Take a bit longer around speaking to them so that they knew what was happening and what my role was in supporting them. Making the connection with their family as well, which was really important because we all process how we feel or what we know by talking to our own loved ones. So not having the opportunity to chat to your family, to be able to discuss even the most basic pieces of information like results for patients, never mind when you're in a very distressing situation where somebody's condition is advancing, was hugely challenging. Having to bring some patients out of wards down to maybe an outpatient area so they could meet with the doctor to get news, and sometimes very bad news. Their relatives literally coming in for the meeting with no chance to have an opportunity to talk to their relative beforehand. It was really challenging. And then the pressure that staff are under working in those conditions, you can see why people would feel lonely and isolated in that situation. And of course, as time went along, the situation was evolving. So while initially in critical care, no face-to-face meetings were permitted, and then over time they were permitted with all the precautions. And you couldn't help feeling for the families where maybe meetings weren't held because that was the advice at the time. Mm-hmm. And then it was all around family supporting with putting on PPE and explaining what was happening and all of that.
And I might just bring you in a bit later on as well, again, Catherine, just about how you manage some of those challenges actually in a moment. But I think, I think Catherine's talking there about a lot of the reality that staff are facing on the ground in relation to just basic communication and the challenges that COVID has brought for people. And just looking at some of the pictures here on our screen, you can see, just imagine yourself trying to have a conversation with somebody who is in full PPE and the patient wearing PPE themselves, and also looking at the impact for our staff as well. When you see the nurse's face there or the doctor's face, who's damaged from wearing a mask all day. So really challenging, really very difficult circumstances for everybody involved, patients, their families, and our staff. As well. So I suppose just looking at managing the communication challenges, and the first thing to say is that the fact that we're in a pandemic situation does not mean that open disclosure should not happen. It still must happen, and we must try to manage it as best we can and as kind and a compassionate way as we can. So in relation to the first meeting, obviously we always prefer the face-to-face meeting, but the situation has to be risk assessed, and you can get help from infection prevention and control around this and make sure that the appropriate PPE is used, and talking that through with the patient as well. If the family can't be available, they can't visit, is having somebody there to actually be a support to the patient, be it a PALS person or a patient advocate, but somebody or a member of staff on the ward who can be there to be that support person, somebody that they maybe have built a rapport with. Connecting the family via technology using video or telephone or whatever. I know they were using FaceTime in some organisations as well, through iPads, phones, etc. And also maintaining the principles of confidentiality as well, as far as is reasonably practicable in these situations. Using visual aids, and I saw a presentation recently where they were using these little flashcards. It was from cardmedic.com, and there's some very useful little flashcards on there that people can use just to support you in trying to communicate in this difficult situation. And managing the information that you do give to the patient as per the HC open disclosure policy. So the same information has to be provided, but maybe in a bit a slower and different way. In relation to the formal open disclosure meetings, again, we would say face-to-face meeting is better if it is safe to do so, and I will just reiterate the safe there. We cannot be bringing patients or their families into risky environment or exposing them to any risk of getting COVID-19. So again, involving the infection prevention control and referring to the HPSC for guidance on this. So risk assessing the situation, making sure there's appropriate space to meet the physical distance and keeping the numbers of attendees down at these meetings, making sure that the appropriate level of PPE is available, and it is available for staff and for the patient and staff attending meetings. And also thinking in advance about who is attending with the patient and making sure that there are people who aren't in vulnerable groups coming into that situation. Making sure that we have good hand hygiene and cough etiquette, and that any potential risks are acknowledged, and that all of that equipment is available in the room. The designated person or key contact person is really critical in this circumstance here in relation to communicating with the patient and their family before the meeting, talking to them about how the meeting will be conducted, about the need to wear PPE, to explain what the PPE is about, why they need to wear it, what's involved in it, reassuring them about they'll be given some help putting the PPE on and taking it off, and agreeing a date and a time where and a meeting point where they can actually meet with the patient and their loved ones, and help them putting on the PPE, bringing them to the meeting room, making sure of their comfort, explaining the personal distancing requirements and the reason why the room is set up, and maybe not quite the way we'd normally do these meetings, and that's the fact you have to have the distancing there. And then you would conduct the meeting as normal, as per the HSE policy, going through the assist model of communication. But I think in opening the meeting, the introductions are really important. So the hello, my name is, and as Catherine said, having your badges available so people can see the name clearly. They need to know who the person is, what their role is. So very good introductions to begin around who is the lead disclosure, who else is in the room, and what their roles are. And again, as Catherine said, sometimes even just having a picture on your name band can be very helpful here to make that human connection. I think just to start off the meeting by acknowledging the fact that people are wearing PPE and that it can be very threatening and it just isn't comfortable for people, but to acknowledge that and just say, listen, this isn't the way we'd like things to be, but we really want to do our best to have a full and meaningful conversation with you today, despite the challenges of doing this through wearing the full PPE. And when we're having these conversations, obviously, our words are so important. We still have our non-verbal cues, but the words and tone of voice are really important. To speak clearly, to speak slowly, provide information in small chunks, and to check back with the patient and their family to make sure they understand. And obviously our non-verbal cues are so important as in all communications. Demonstrating empathy and compassion around the situation, whatever has happened, but also the fact, the challenge and circumstance that the meeting is being held. I say using visual aids where you can to assist that communication process. And then agreeing at the end of the meeting, reiterating the key points, agreeing the next steps, and then that there'll be follow-up with that patient and their family. So the key contact or designated person will then assist the family with the decontamination and removal of PPE post-meeting, And after the meeting then, we always recommend that the designated person will arrange time to actually call the patient and their family after the meeting, just to check with them how everything went for them at the meeting. Were all their questions answered? Did they understand everything? Was there anything outstanding for them? And just to see what their feelings were around the meeting, whether they felt they were treated with dignity and respect, and whether they felt that they had an appropriate apology, etc. But that follow-up call is so important. So managing open disclosure when it's not safe to do a face-to-face meeting. And again, this is very important. And I know I'm going to bring Catherine back in here in a moment actually around this. So we have to consider an alternative method of communication. And just because the open disclosure, it's not feasible to do face-to-face meetings, not an indication not to do open disclosure. So considering how else we can do this, so either by telephone, by video, through Zoom, through WhatsApp, whatever is feasible for the patient. And again, that, the designated person will contact the patient and say that, the doctor or whoever it is wants to have a conversation with them to talk about what happened. And obviously at the moment it isn't safe to have a face-to-face meeting because of COVID-19, and we'd like to still have that meeting and discuss with them what is the best option for them. You may need to have some IT support, and obviously using secure networks where feasible, your IT department can actually give you help with all of that. And preparing for a telephone meeting is just the same. You need to prepare the same as though it was a face-to-face meeting. So getting, establishing who the lead disclosure is going to be, getting your information, your facts available, considering what the apology is going to be, what you will need to acknowledge to the patient, and considering the next steps and care plan for that patient. So managing the meeting again, as per the HSE open disclosure policy. So with the telephone call, you have to consider what is different around doing open disclosure via telephone. And when we think about how we communicate, our non-verbal cues are such a big part of the communication process. So we're going to lose the non-verbal cues if it's just a telephone conversation that you're having. That's different now when you're doing a video conversation. So we're going to be focusing on verbal and paralinguistics. So it's your words and your tone of voice. And it's really important that the words and the tone of voice match each other. Okay, so that you're portraying empathy and compassion in the way that you're talking to the patient, that you're focusing, speaking clearly, small bits of information at a time, and then checking understanding as you go forward. Using long sentences in a telephone call is difficult, and the patient can get lost in the information they're receiving. So short sentences, keep it focused, and check regularly with the patient that they understand what you've told them. And again, to offer a face-to-face meeting at a later stage if required, or again, if it's feasible or safe to do so. So Catherine, I might bring you back in here again now to talk about your experience of doing some of the video meetings, for example.
Yeah. A virtual meeting by video, sometimes with the patient in the room and a relative at home. A lot of our work would have been around preparing for that, contacting the relative to let them know how the patient was and how they looked and what to expect, what they would see when the call would be made, what professional was going to be speaking, maybe the consultant, who they were. We would do a test to make sure that we had a connection, that the Wi-Fi worked in an area like intensive care or coronary care or the general ward, that it was a private area, that the person would be able to speak without anybody overhearing the conversation. And then letting the patient, the relative know, what condition the patient was in, if they were going to be able to speak, and how they would look, whether wearing a face mask or had oxygen on, or what equipment would be visible around the bed. But in actual fact, it meant that the patient could see their relative without a mask at home, and we would have had the video call then, and of course managing that carefully to be aware of any questions that might need to be asked, and supporting both the patient in the bed and the relative in getting the information that they wanted, and then doing the follow-up call with the relative to make sure that they were happy at their end. But quite often then doing a further virtual visit for the patient and relative, so they had an opportunity to discuss the information that had been given in privacy, if it was possible, to let them have their own conversation so that they could talk about the information that had been given to them. So it did take quite a bit of time, but it was time well worth investing in, and to provide them with every kind of support that you could give.
And I know, Catherine, you were talking about how important that role, the designated person or patient liaison person, has been through COVID, and being that communicator and that person looking after all of those things that you were just talking about there. They're so important. Even that follow-up call after the meeting, or facilitating that communication process between the patient and their loved one again after the meeting, so they can talk about what happened, which we would do normally after any meeting, that the patient and family would go home and talk about the meeting and how it went for them. So to be able to facilitate it again through the video has been, again, something that's so important, and we might not even think about, sometimes. So thank you for that, Catherine. So just looking at, moving on then to open disclosure in relation to COVID-19. And again, it's so important that, that when there is a patient safety instance that relates to COVID-19, that they are managed in an open and transparent way, and that anybody who is affected by COVID-19 is communicated with openly in relation to their diagnosis, care and treatment, any risks around that, but also around the source of infection. So if, for example, there are any contributory factors in relation to the patient getting COVID-19, is that, that information is made available in an open and transparent way. But also to be really, really careful around the rights of confidentiality of patients and for staff. So if a patient is on a ward and they contract COVID-19, that whereas they can be told that they've been exposed to COVID-19 on that unit, they cannot be given information around the name of the patient or the member of staff that perhaps was the index case in this example. So our scripts that are used by the contact tracing service and case management service are very clear in that we have to protect the confidentiality and the rights to data protection for anybody who contracts COVID-19. But as I say, we can say while you were a patient on X ward or in X service that you were exposed to COVID-19, and that's as much as we can give really. So again, empathy and compassion are key, and we have brilliant contact tracing service and people who are trained to actually, give this news to people as well around the fact that they've been exposed or they're a contact or that they have COVID-19. So that's done. And we've been working with some of the scripts around the language that can be used there to make this communication process and contact tracing as compassionate as possible.
Thank you. Sorry, Angela, can I just come in there?
Yes.
It's a particularly difficult situation if a patient is in contact with COVID in the service, because being mindful that the family are not permitted to visit, and they want to believe that everything is being done to protect their relative, and they would be particularly angry then and upset and distressed and frightened when they get this news. And I suppose we were always really mindful of that. Because they would just feel really let down that they weren't allowed to visit, they couldn't come in, and now this had happened. So it was just a particularly difficult situation for everyone involved. And you had to just be really conscious, put yourself in their shoes and think, how would you feel if it was your relative? And equally for the patient then, very frightened that they've now contracted COVID or have been in contact with COVID, and what does that mean? Really, really frightening for them, even though, they may not, their condition may not be negatively impacted by it, but really frightening at the same time.
Yes, and I agree totally, Catherine. And I think, again, patients in these circumstances and their families will just be so grateful of complete openness and transparency, and the fact that they are supported and, you know, they are reassured, and that communication is maintained with them to give them information around their loved one and obviously their care and their treatment, but also around what's been done to address the situation as well in relation to the learning. And there's been so much learning for us as for the HSC through COVID-19 generally, in the way that we work, the way that we do our training programs, the way that we communicate, etc. So again, all of this is a huge learning point for us in relation to in quality improvement going forward in the way that we do our work. But just looking on then to the area around staff support, and this is something that's really close to my heart. And when I watch all the TV programs and I see our frontline staff, you know, and what they're dealing with, and you know, our team have done a lot of work on the whole area around the staff support program and making sure there are adequate supports in place, and just bringing that message home to everybody, you know, considering the physical and psychological impact of COVID-19 and the social impact of our staff, and including our staff working in our contact tracing services. Just walking in their shoes, as Catherine said, and the support from peers and managers is absolutely critical here, that people feel valued, that they feel that they are minded. Looking after our staff, minding them and looking after their welfare is so important here, particularly with our frontline workers. And compassion, it's not just compassion to patients and families, feeling and demonstrating compassion towards our staff members is so important, and promoting self-compassion and being kind to each other and kind to yourself is really important here as well. Psychological support and having access to psychological support is really important, and engaging in things like team talks, Schwartz rounds, and, you know, making sure the staff is aware of what support services are available to them and how they can access those services, again, is really important. So communication must be from peer to peer within the team, and the support as well for everybody that's involved in this. And one of the areas around that's been challenging as well around maintaining the principle of open disclosure during the coronavirus is how do we maintain training for staff, because we know to engage in effective open disclosure requires not only training but a lot of leadership as well. So, and obviously at the moment it's very difficult to run face-to-face programs, which is again size of rooms, numbers that can attend, and personal distancing, staff, you know, problems with staff resources, etc. So just say, well, training is still mandatory and 3 yearly refreshers are required, and we need to look at how we can deliver training safely if possible, and we do say to our trainers, only deliver training if you have an environment where it is safe to do so, that you have a room that is big enough to do that, to allow for the personal distancing, so you have small numbers. And there is a document that has been produced by the HSC or the HPSC on guidance for delivering face-to-face education during this pandemic situation, and that document is available on the website. And if anybody wants a copy of it, they can email the Open Disclosure Office and we can send it out to you. We've been advising our trainers to promote Module 1 of the e-learning programme, which was launched in April. And I think we've around 27,000 staff have completed that programme for up to now between April and October. So again, it gives a good overview of open disclosure and the principles of open disclosure, and looking at the patient and staff perspective, and there's an explainer video in there. So we would recommend that you would promote and encourage people to complete this programme. There are 2 CPD appointments allocated to this programme now through the RCPI, and 1 CEU from the NMBI, and also for relation to CORU, that they would do their their accreditation through the reflective process. And the RCPI have also launched, just in recent weeks, their Gateway to Communication programme, which is really targeted at doctors. And this looks at, there's 4 modules in here, but general communication and peer-to-peer communication, and clinician to patient communication, and then managing challenging discussions, and open disclosure is included in that module, and it links out to the various programs that we deliver in the HSC. So again, that program is open to non-medical staff as well, so I would really recommend that, and if people want more information on it, they can email our office as well, and we can get that out to you. So in relation to how we can help on the ground while we perhaps can't deliver the face-to-face training is really to utilise the expertise. There are trainers in all of our hospitals, in all of our CHO areas, to actually access your trainers and your leads. And if you have a difficult meeting coming up and you need a bit of help, they can do a quick bit of training with you on the ground to actually help you to prepare for and manage that open disclosure meeting and support you throughout that. So not to underestimate the great expertise that is out there on the ground that you can access locally to you. And if you go onto the HSE website, hse.ie/open disclosure, you'll see a list of all the open disclosure leads for all of the areas, and you just contact the lead and they'll be able to help you through that. There are numerous resources on the open disclosure website as well that you will find helpful, like pre, during and post-disclosure checklists, sample language you can use, staff support, numerous things are there to help you. So do have a look on there, and documents on how to apologise to a patient effectively as well. All of those you'll find very helpful. And at any time you can contact the Open Disclosure Office, opendisclosure.office@hse.ie, and we're always very happy to help in any way that we can in giving advice, or we can do some virtual training for people if they need it as well. So any way that we can help you, we're more than happy to do that and want to do that. So just looking again at the role, I really just want to emphasise the role of the designated person, key contact person. Again, it is critical. I must admit myself, I know all of you probably who have joined us today have been doing this in some way, be it that you're the risk manager or you're the nurse manager or nurse in the ward, that you may be acting as that liaison person, but that role is critical. It really is. Building up the rapport, maintaining the communication processes, and with assisting the patient and their family in preparing for the open disclosure meeting and being there to support them during the meeting and doing the follow-up with them from the meeting, and also to provide information on the support services that are available. And there are numerous open disclosure resources there, as I say, just to finish off on now. So we have done a lot of work on staff support documents and resources for staff working in the contact tracing centres, for example, and they're on the Moodle platform. The policy is there, and we have written a document now for you on how to manage the principles of open disclosure during the coronavirus pandemic, looking at, as they managing a telephone communication, managing a meeting wearing PPE, and it contains a list of all the staff support resources that are there as well. The e-learning module on HSE Land, and if somebody is going into an open disclosure meeting, they could quickly go in and do that module. It takes about 40 minutes. And just to let you know, we're working on module 2 as well, which focuses on actually how to prepare for and manage an open disclosure meeting, follow on from a meeting, and looking at managing some of the complexities that may arise during that meeting as well. For example, if a patient wants to bring a solicitor or wants to record the meeting. But we are using scenarios in that module 2 around mental health, intellectual disability, ambulance service, so acute GP services as well. So we've got 5 different scenarios built into module 2, just because one of the things that feedback we had earlier was that a lot of our work seemed to be very hospital focused. So we've been trying to do a lot of work around that, and we have some webinars coming up, which we'll talk about maybe a bit later in relation to looking at maybe open disclosure of mental health and maybe intellectual disability services, etc. Again, the link to the Gateway to Communication program is there for you as well from the RCPI. It really is an excellent program. I'd really recommend people to do that as well. And do look at our resources that are there to help you. So that's really the end of the presentation for today. Unless, Catherine, is there anything else you'd like to come in with there that I might have missed out on?
No, I mean, I think we've covered all. I suppose we know that open disclosure can be so challenging even in more straightforward times, but when we have these extra layers of PPE, restricted visiting, and all of that, it's hugely challenging. So any support that we provide to staff to assist them. We're delighted to do it, and equally to help patients and families at this time.
Thank you, Catherine. So I'll pass it back to Siobhan now. We're happy to take any questions that are there.
Yeah, Angela and Catherine, thanks very much for that. We do have one question just around the concern around issues around patients or family recording meetings. And I know you mentioned that, Angela, there in your presentation.
Yes.
Any guidance for people with regard to that?
Yes, this is something that comes up regularly, and we actually sought some legal advice on it again recently. And first of all, I suppose to answer the question, can a patient record a meeting without your consent? And the answer is yes, they can. And there's no law preventing them from doing that. And the reason why that is because they're recording their information, basically. So what we would say to people is, if a patient asks to record a meeting, that's a bonus. So if they do ask to record the meeting, maybe ask why they want to record the meeting, because very often a patient wants to record the meeting because maybe they just feel they won't remember everything after the meeting. They want to go back and give information to their family. So maybe just letting them know that there will be minutes of the meeting taken and provided, and if that makes a difference, then, you know, they may not want to record then. But if they say, listen, I really want to record it, then we really should facilitate that for them, and they can record. But we would recommend that you would record the meeting as well, because we do know from the past that, you know, recordings can be tampered with. On a positive note, recordings can be very helpful in that they can protect the member of staff involved, in that they are a very accurate reflection of what actually happened in the meeting and what was said and how something was said. So our general advice to people is, you know, stick to the facts. You shouldn't be saying things to patients that you can't stand over at a later date. Always assume you're being recorded. Not many people record, but some will, and some will record without even you knowing they're recording the meeting. So always assume you're being recorded. Stick to the facts. Never engage in anything that in relation to blame or defamation of another member of staff or a service. You don't want to go down that route of defamation. So stick to the facts. Manage the meeting professionally, assume you're being recorded, and I think, you know, that you won't have anything to worry about then. I hope that answers the question.
In addition, then, that issue would have come up a little bit with the virtual visits by WhatsApp, and some family members would ask to record the visit because they want to share it with other family members. So we would always ask the patient if they were happy to consent to that. I suppose, as Angela said, we'd be glad to know that they wanted to record. There was an occasion where I had a sense that somebody was recording and they hadn't asked, and I did ask them if they were recording and just said that it would have been better if they had let us know in advance. But generally speaking, it wasn't a problem. And as Angela said, you wouldn't be saying anything or showing anything or, you know, talking about anything that you wouldn't be happy to have shared. If the patient is comfortable about it and happy and gives their consent.
Yeah, and I think, again, never engage in speculation either. You know, as I say, if you don't know the answer to something in a meeting, don't speculate or make or second guess it. Just say, I don't know the answer to that, but I will go away and try and find out more information for you. So again, just be careful around speculation and blame are the two things to be really careful with. So stick to the facts is the main thing there, and manage the meeting professionally, and it will protect you as well.
Thanks very much, Angela and Catherine, for clarification around that. Any other questions that anybody would like to ask Angela or Catherine? Just putting it out to our participants. I'm just wondering what's next for Open Disclosure Programme, Angela and Catherine. What are your future plans for the programme over the coming months?
So I suppose in relation to our own programme, we've been, I suppose, a bit restricted ourselves and not being able to get out to do the train-the-trainer programmes, etc. So we are currently running a number of webinars, and recently we've been running just update webinars for people across the country to let them know what's happening in relation to open disclosure. And we've run 3 of those to date, and they've been really well attended. I think about over 200 people have attended those webinars. Coming up, we're going to be doing some webinars on the legislation, so the current legislation on the Civil Liability Amendment Act and regulations, and also what is coming in the Patient Safety Bill. And work has recommenced now on the Patient Safety Bill, which is bringing provisions for mandatory open disclosure. And a lot of our work next year is going to be around the preparation for that bill and developing training programs and resources to assist services in the implementation of the mandatory provisions around open disclosure. The other thing we're doing a lot of work on at the moment is in relation to open disclosure training for medical staff and building the training into all of our programs for medical staff. So just into the RCPI program with the communication, but also we've contacted, Dr. Philip Crowley has contacted all of the undergraduate programs, and we're currently doing an analysis of how much open disclosure is included in undergraduate programs for doctors, nurses, midwives, and healthcare professionals. And the information we're getting back is very encouraging in relation to that it is there, it is visible. I think a further piece of work is going to be needed to look at how much training is in these programs. It's there, but how much is there. We've also built open disclosure now into the training program for our NCHDs, and it's now on their national staff record system. So they have to now, when they actually rotate from service to service, they now have to show evidence of open disclosure training and uploading their HSE Land Cert onto the DIME program for NCHDs through the National Doctors Training Program. It's also been built into the program for our interns as well. So from the next intake of interns next June or July, they will be required to show evidence of open disclosure training as well. So a lot of work with the colleges as well and building it in through the various programs as well with the colleges. So a lot of focus on our doctors at the moment. We're going to be doing some webinars as well, so some focused webinars on managing the challenges of open disclosure in relation to mental health, for example. So looking at how maybe mental health services rolled out an open disclosure program, and also in relation to intellectual disabilities, so looking at some of the challenges that people face with maybe involving a person with an intellectual disability in the open disclosure meeting and making sure all of the supports are there. Looking at open disclosure relating to maternity services. So you'll be seeing a number of focused webinars coming up into some of just really drilling down into some of our services. Equally, if there's any kind of topics that you would like us to cover, we'd be really interested in hearing from you around those as well. People want to use a chat function for that. We would really like to hear what you would like us to do.
That's great, Angela. And they could also probably email you at your Open Disclosure Office email address too.
Yes.
So there's just some very positive. Thanks a million for that, Angela and Catherine. And it was great to hear, I suppose, Catherine's first-hand experience of working in an acute setting, and there's been feedback through the chat with regard to that. So thanks very much, and it was really helpful, and I think there was lots of practical advice for people there. So thank you to you both.
Express my thanks, Siobhan, to all of the quality improvement team, to Greg Price and Philip Crowley, for their continued support with this programme as well. It's been a difficult couple of years for open disclosure, but we're kind of, moving forward and, hopefully improving the programme all the time. We're learning a lot on our journey, and we really want to hear from people on the ground, though, because we really want to deliver now what people in our services need, and we're really reaching out to services now to contact us and tell us what we can do to help them on the ground. So if you have ideas, please come to us.
Great, and I think that some people are saying that they'd welcome specific webinars for mental health. Definitely, it would be great.
Yeah.
And indeed, thanks very much for all the valuable and important information. So that's great. So thank you both, and we'll hear a lot more from you over the next coming months, I'm sure.
Okay,
so thanks so much.
Thank
so
you. Just
scrolling on there, Angela, if you wouldn't mind, we'll just finish up there. And as I say, this webinar is being recorded and will be available on our QITalktime on the website, the HSE Quality Improvement Team website. And I suppose here's our plan just for the next coming months. The next webinar is booked in for the 17th of November, and it's around the Spark program, is my understanding. And then on the 1st of December, we'll also have a look with Aoife de Bruin and John Fitzsimons around the importance of stories and what makes an effective team during COVID. So there's an interesting topic as well in December. So any suggestions around topics can be forwarded to either myself or Naomi, and it would be great to get some further suggestions for topics for the following year. So thanks very much. So we're looking forward to seeing you on the 17th of November, and many thanks and to Catherine and Angela, and goodbye. Thanks very much. Bye.
Okay, thanks everybody. Bye. Bye.